Good evening, dear students, ladies and gentlemen. Welcome to our next edition of our case presentations in nephrology by the Indian Society of Nephrology. And we keep on getting requests that how can we access the recorded videos. So most of them are being uploaded in the ISN YouTube channel. And the people who have registered, we are also sending them direct links to the videos. And I would request all of you to please register for the event in the link provided. That is because we tend to send you the important questions discussed, the articles on that topic, some other about the future cases, and the link of the related cases on your email. So please register. And I would also take this opportunity to appeal to all of you, especially the students, to please volunteer for the case presentation. Very happy to share that Dr. Jwala and the previous person who discussed have all volunteered, and I'm very sure that they were quite benefited. And in today's session, we have an interesting case. We have a very interesting case in nephrology, and for a change, what we have done is that we have gone one step further to have a good clinical discussion, and we will go ahead with this case without knowing what the case was. And Dr. Jwala, who is presenting, was also told was given the case a few hours before this presentation. So let us see how it unfolds. And I am very sure this will help us in getting back the old charm of the clinical medicine. And Dr. Jwala will be presenting the case, will be moderated by Professor S.K. Agrawal. And after that, we'll have the question answer session. I would like to welcome our moderator for today, Professor Sanjay Kumar Agarwal. In fact, it's my great pride and honor to be introducing Sir, who is, I would say, a legend in nephrology all over the world. He is presently working as a consultant of nephrology and kidney transplant at the Marengo Asia Hospital, Gurgaon. But all of us know him as the previous professor and HOD of nephrology and AIMS, Delhi. And in fact, I would be very honest in admitting that I am totally overwhelmed with emotions to introduce my teacher. And to be very honest, we are here because of him, and he has been a great mentor. And Sir does not need any introduction. He has groomed more than 30 years of all the nephrology students passing from AIMS. And AIMS, as you all know, is one of the best nephro centers of the country. And be it every field, be it academics, whether it is publications, research, awards, Sir has excelled in everything. And he is the council member of NAMS and member oversight committee of PM, NDP, NPCDCS, and various committees by the government of India. And he has been chair of the Indian CKD group. All our national and international forum, Sir has been an active member. He has also been quite engaged in publications and scientific writing. He is presently the editor-in-chief of the prestigious Seminars in Dialysis and was previously the editor of our IJN. Sir has numerous awards to his credit from national and international societies and various forums. And he has got 17 orations, 14 fellowships to his credit. We all learned research in nephrology from Sir, and he has more than 30 funded research projects and more than 300 publications. And I mean, we can't, if I start speaking about him, the whole class will be exhausted. But I just want to add that on a personal note, Sir taught us not only to be a good nephrologist, but also to be a good human being and a good doctor. So we are really proud to have Sir, and I am very sure that all of us will be benefited by the class today. So our case will be presented by Dr. Jwala, who is a senior resident in nephrology from AIMS Nagpur. And you all know the basic rules of participating, that you all have been muted. You can put your chats and comments in the chat box. I would also request that as a practice, all the students can try to answer the questions that are being asked in the chat box. And any doubts you have, we'll always try to address that. I would also appeal to all of you to send us your feedback, suggestions, and comments. And as a small change, so what we'll do is that we'll have the history. After that, some round of discussion, then the examination, then again discussion, and then sir will be sharing slides in which he will try to unfurl the investigations and have a discussion on that. So this is our WhatsApp group by which we send you updates. I would request all of you that you can scan this and join this, so it becomes easy for us to communicate with you all. So that's all. So I would unshare myself, and I would request Dr. Jwala to please share a screen. Yeah, we can see your screen.
So, sir, can I start?
Yeah.
Good evening, sir. Today, I would like to present the case of Shilpa Tempurne. She's a 39-year-old female. She's resident of Nagpur, and she's educated up to masters. She has completed masters of computer management, and she was a housewife. And her presenting complaints are loss of taste and appetite for the last 2 months, and tiredness for the last 2 months, and decreased urine output for 1.5 months, and pedal edema of 1.5 months duration. She was a non-diabetic for the last 5.5 years, and she was on insulin, and she says her blood sugars were controlled. She was apparently normal 2 months back. Then she noticed loss of taste in her mouth, especially inability to appreciate salty taste, and hence she could not enjoy food and she developed aversion to food. And her food intake reduced, and she lost about 15% of her body weight in 1 month period. From a weight of 44 kg, she became 37 kg. She also says that she experienced tiredness. Initially, she used to do all the work at home, but she found difficulty in doing household work like cooking food, cleaning her cleaning room. And she also noticed that in the next 1 week, her urine output decreased. Initially, she used to pass urine about 5 times in day, and she used to pass 1 time at night. But her amount and frequency of urine output reduced, and in the next 1 week, her urine output reduced to less than 100 ml per day. She also noticed pedal edema, which was bilaterally symmetrical. It was not. It was associated with facial puffiness, and this pedal edema was not associated with pain in the legs. There was no history of loss of smell or altered odor or altered taste like bitter or metallic taste in her mouth, along with loss of taste. And she did not experience any nausea or vomiting. There was no history of any painful urination, blood in urine, or cola-colored urine, or frothing of urine. There was no history of breathlessness or yellowish discoloration of skin, eyes. No history of joint pains or swelling in joints. There was no history of fever or chills. There was no history of hair loss. There was no history of rashes, oral or genital ulcers, or photosensitivity or Raynaud's phenomenon. There was no history of cough or coughing out of blood. There was no history of any headache, discharge from the nose, or bleeding from nose. There was no history of hearing loss or sensation of fullness in ear or any discharge from the ear. There was no history of any tingling, numbness, or burning sensation in her feet or any other part of the body. There was no history of loosening of chapels without awareness. There was no history of any focal deficits. There was no history of any dizziness or fainting on rising from sitting or lying down position. There was no history of any blurring of vision or pain in her eyes or redness or flashes. There was no history of any abdominal pain or postprandial abdominal pain or blotting sensation. There was no history of any dark, tarry, sticky stools or loose stools or blood in stools. There was no history of painkillers or indigenous drug use. By the second week of March, she went to local hospital, and there, after doing blood investigations, she was told that her hemoglobin reduced, and she was transfused 2 units of red blood. And she was also told that her creatinine has rise to 10, and hence she was referred to AIIMS Nagpur. Or at AIIMS Nagpur, because of the severity of the disease, she was started on dialysis. Dialysis was initiated through HD catheter placed on the neck, and she underwent dialysis once in every 3 days. She underwent some blood investigations, and she was told that she needs to take further treatment for her disease condition. and she was told she had to take medications which will predispose her to infections. She received injection for 3 consecutive days. Then another injection was given after explaining that there is of hair loss, developing infections, infertility following this treatment. Hence, first injection was given on 25th March. And after second 2 weeks, she was given next dose of the injection. But after the second dose of injection, she developed tonic posturing of body associated with loss of consciousness, not associated with frothing from mouth. It was associated with staring of eyes, and it lasted for only 5 to 10 seconds. And since she was in the ward, she was given IV medication, after which she fell asleep. And she was asleep for around 2 hours, but she does not remember the episode. Only the husband told about the episode. And she underwent some other form of dialysis as well, and she also underwent renal biopsy. Following this treatment, after around 1 week of starting treatment, her urine output increased, and currently she is on drugs to increase her urine output, and it has increased up to 1500 ml per day. And her dialysis frequency has also decreased. Now it is once in 7 to 8 days. She says her pedal edema has also subsided and appetite has improved, and weight has improved to 43 kg. She says her blood pressure values were normal initially, but after coming to AIIMS Nagpur, she was detected to have increased blood pressure, and for controlling blood pressure, she was given one antihypertensive drug. Past history, she is diabetic for the last 5.5 years. She was diagnosed to be diabetic during the first pregnancy, that was around at 33 years of age, and at 8 weeks of gestation, when she went for her checkup. After doing blood sugars, it was deranged and she was told to be diabetic, and she was started on insulin. For the last 5.5 years, she is on insulin, and she says her blood sugars are controlled, but further investigations were not done. There is no previous history of high blood pressure, any kidney disease, any pedal edema, jaundice, any history of seizures, or any history of blood transfusions. Family history. She is the first child of non-consanguineous marriage. There is no family history of diabetes, no family history of kidney diseases. Menstrual and marital history. She achieved menarche at 14 years of age. She had regular cycles of 4 days bleeding, 2 pads per day, and her last menstrual period was on 11th of January. After that, she did not have periods. And during her first pregnancy, that is at 33 years of age, she was diagnosed to have diabetes. And that first pregnancy, she has a live child of 5 years duration, 5 years age. And it was an elective LSCS because of meconium stained amniotic fluid, and baby's weight was around 2.5 kg. Personal history. She's a non-vegetarian. Her sleep is normal, 6 to 7 hours per day. She belongs to lower middle class.
You can go for your differential diagnosis or diagnosis.
So from the history, I would like to keep a syndromic diagnosis of rapidly progressive renal failure. It can be due to rapidly progressive glomerulonephritis more than other causes of RPRF. In RPN, I would like to keep lupus nephritis or ANCA-associated small vessel vasculitis. It could, other than glomerular, it could be tubulointerstitial, acute tubulointerstitial nephritis or TMA, and hence an acute on chronic kidney disease. And she's diabetic and she has anemia.
So you are saying your diagnosis is rapidly progressive renal failure, and out of that it is rapidly progressive glomerulonephritis. But diabetes and anemia is just a component. You are not trying to explain everything on diabetes or anemia. So from renal point of view, we can leave these two. These are associated things, or you want to explain every feature on diabetes alone?
No, sir. Diabetes is kept as a comorbidity.
So this is a comorbidity. So your diagnosis, tell me why you are saying rapidly progressive renal failure?
Sir, Because she has developed loss of kidney function over days to weeks, and she has history of
No,
oliguria.
sorry, what is the evidence that she has loss of function over weeks or days?
2 months ago, she was apparently normal. She did not have any symptoms, but we are not sure. We don't have her blood investigations. From the history, she was apparently normal. There was no history of any renal dysfunction, and she developed loss of taste, loss of appetite, which could be due to uremia as well. And her urine output has decreased from normal to around 100 ml per day, less than 100 ml per day.
No, that is all right, but we can't say rapid progression only on a basis of a symptom. The first creatinine, if I correctly remember in your history, is 10 milligram percent. What is known?
Yes, sir.
And she is computer graduate.
Yes, sir.
So she gives any history of creatinine done before that value of 10 milligram percent?
No, sir, she does not have any value.
So you have got only single value of 10 milligram percent, and before that you have no other documented value to assess or to say that there is a rapid deterioration.
Yes, sir. That's why I've placed the possibility of acute or chronic kidney disease also.
No, that will come later. But your outer differential, your first differential is rapid progressive renal failure.
Yes, sir.
I just want to know that out of these two, we can leave diabetes and anemia for the time being. You have kept two differential, rapidly progressive renal failure and acute on chronic kidney disease.
Yes, sir.
So can you say that on what basis we have history-wise no evidence to say that there is a rapid progression?
So, but her symptoms only for last 2 months.
No,
Which
that is all right, but tell me how many of patient of chronic kidney disease we often see where apparent history is very short, 2 months, or it may be sometime less than 2 months also. So just because she has no other symptom before, can we really exclude chronic kidney disease existing?
no, sir, we cannot exclude because she has history of anemia also from the history. So
That presence of a history of anemia that favors out of your two differential, rapid progressive renal failure versus acute on chronic, which of these two favor presence of anemia?
anemia is more likely to be in acute non-chronic kidney disease.
So you have got one feature which suggests that she might be having a pre-existing chronic kidney disease. So why not put acute on chronic kidney disease as the first diagnosis and rapidly progressive renal failure as a second?
From the course of her illness during the last 2 months, she presented with oliguria and all, but after treatment, there is some improvement as per her history. She says her urine output has improved. She is better now. So I feel rapidly progressive renal failure is over acute non-chronic.
Okay, on out of broad diagnosis of rapidly progressive renal failure, you are saying that you're out of this rapidly progressive renal failure, you are making diagnosis of RPGN. On what basis you are saying that out of rapidly progressive renal failure, it is RPGN?
From the history, there is history suggestive of oliguria to progressing to anuria. History suggestive of pedal edema, but there is no history of hematuria, which is against her.
So you are telling negative history. You tell me what positive history is on basis of which you are saying that this is RPGN.
Short course, improvement in her symptoms, and history of pedal edema, history of pedal edema and oliguria, progressing to
So
anemia.
you see, his first creatinine was 10 milligram percent.
Yes.
And irrespective of any cause of renal failure, edema may be just a component of advanced renal failure itself.
Yes.
So in that case, does edema suggest a glomerular disease?
If it was component of renal failure only because of decreased output, she would have developed pulmonary edema, which is not there in this patient. It was highly likely that she would develop other features of fluid overload also.
Other features of?
Fluid overload.
No, then can you suggest that is there any really difference between fluid overload and edema? Are these two things same?
No, sir, they are
On
different.
this patient also, although she gives history of edema, but are you saying that she was in fluid overload also?
No, sir, she is less likely to be in fluid overload because she denies any history of breathlessness, orthopnea, so she's less likely to be in fluid overload.
Can you make it, can you explain why there is a difference? What is the basic difference between fluid overload and edema?
Fluid overload, it is mainly the intravascular volume,
Okay.
but edema, it is the interstitial compartment.
Okay. So even though we take your diagnosis at the moment, rapidly progressive glomerulonephritis, out of that you are saying your first differential is lupus nephritis or ANCA-associated small vessel vasculitis. Can you give me some pointer which are favor of? Let's first start with lupus nephritis and then ANCA-associated vasculitis. So what are the feature in this which on basis of which you are putting first diagnosis as lupus?
Sir, her age is 39. Lupus usually 15 to 45 years.
But then there are so many diseases which will be in the same age group.
Yes, sir.
So just age doesn't suggest that you can make clinically lupus as one of the first differential.
Yes, sir. She also has, she's a female, so she has more predisposition for lupus.
Okay.
Then there is history of anemia, significant anemia, and weight loss, loss of appetite. Although the symptoms can be explained by uremia as well, or weight loss and all can occur in ANCA as well.
And these symptoms which you are telling are not component of defining lupus as per the American Rheumatology Society also. So the
Yes,
only feature which you are favoring is that she is a young female.
yes, sir, and female.
Other than there is no other history to or feature in history to suggest that you can make lupus as a first differential out of RPGN.
Yes, sir. But SLE can present, first presentation can be lupus nephritis as well in some patients.
That is fine. But then for that we need certain other thing like examination and investigation. We are discussing at the moment on the basis of a history.
Yes, sir.
And what features suggestive of a on basis of which you are putting second as a ANCA-associated vasculitis?
For rapidly progressive, she has history of anemia, which can be there in ANCA. Weight loss is there, significant weight loss is there.
But
And
the anemia and weight loss, are these really relatively specific or suggestive of vasculitis?
no, sir, they are not specific.
These are vague symptoms which can be there in your second differential like acute or chronic kidney disease.
Yes, they can be explained by CKD as well.
So that will go more in favor of your second differential rather than ANCA-associated vasculitis. Clinically, on basis of history, it will be at least your history didn't suggest any feature on basis of which we can put this as a differential diagnosis.
Yes.
Now, then your rapidly progressive renal, you have put differential of acute tubulointerstitial nephritis within the rapidly progressive renal failure. This is in fact it's a differential of rapidly progressive renal failure itself. On what basis, what features suggest acute tubulointerstitial nephritis?
Initially, she did not have significant hypertension. In acute tubulointerstitial nephritis, hypertension is not seen. Other than that,
But then she started having hypertension also.
yes, towards the end, there is hypertension as well.
So are you saying that once the initial stage of acute interstitial nephritis doesn't have hypertension, but at a later stage, patient develop hypertension?
No, sir. No, sir. Acute interstitial nephritis usually will not have hypertension, will not have edema.
Okay. And what feature are there on basis of which you are saying it can be thrombotic microangiopathy?
Thrombotic microangiopathy because of significant anemia, renal involvement requiring dialysis, and it can be secondary to diseases like in this female. We should consider secondary to diseases like SLE or other causes causing RPG like IgA nephropathy.
And on what basis you are saying it can be acute on chronic? What is feature which suggests that she might have a chronic kidney disease pre-existing?
She is diabetic, so she may develop diabetic kidney disease, which I'm not sure.
How much long history is of diabetes?
5.5 years.
So is the 5.5 year at the time of diagnosis she was 33? Is that a common progression of diabetes that a 33-year-old female developing chronic kidney disease at the end of a 5 year?
From history, I could not make whether it is type 1 or type 2 diabetes.
But was there any history to suggest whether it can be type 1 or type 2? Any history of which can, on basis of which you can say?
No, sir.
What treatment she was getting for diabetes?
She was on insulin. Insulin, it is more probable to be type 1 diabetes.
Yeah. So once she was maintained insulin from the beginning, chances of a type 1 diabetes is more as compared to type 2, although type 2 at an advanced stage may still require insulin. So at the moment, you are still keeping both this rapidly progressive glomerulonephritis, which we cannot interpret whether lupus or ANCA, associated vascularitis, and acute on chronic kidney disease.
Yes, sir.
So keeping these two in mind, in addition, diabetes mellitus and anemia as a comorbidity, let us go for examination.
Examination, she was conscious, oriented in time, place, and person. She was moderately built and poorly nourished. BMI was 17.5. Pallor was present. No icterus, no cyanosis, no clubbing, no lymphadenopathy. Bilateral pitting pedal edema was present. Her pulse rate was 92 per minute, regular, normal volume, normal rhythm, normal character, no radiofemoral delay. All peripheral pulses were felt bilateral symmetrically. Blood pressure in right upper limb was 153/87. In left upper limb was 150/80. And in left lower limb was 160/85. There was no orthostatic hypotension. Respiratory rate was 16 per minute. Temperature was 98.2 degrees Fahrenheit. Head to foot examination. There was no redness of eyes. There was no RAPD. There was no malar rash, no saddle nose, no rashes or ulcers. Oral cavity was normal. Nails was normal. Fundus was normal. Systemic examination. Respiratory system. It was bilateral normal vesicular breath sounds. Cardiovascular system S2 was present. Abdomen soft non-tender bowel sounds were present. CNS cranial nerves were normal. A motor system was normal. Reflexes were brisk. A bilateral plantar was flexor. Sensory system was within normal.
So, can you summarize that? What are the positive finding in examination?
Sir, her BMI was low, 17.5. She had pallor and bilateral pitting pedal edema, and her blood pressure was raised. There was no orthostatic hypotension. Uh, Only these findings were there, sir.
So, can you add whether this blood pressure was with some antihypertensive or without antihypertensive?
She was on Nicardia single drug,
She was on
single antihypertensive.
single antihypertensive. So, she basically have anemia, edema, and mild hypertension.
Yes, sir.
So, with this examination finding, going back to your differential diagnosis of RPGN versus acute on chronic, can you differentiate that out of these two, which one you would like to keep as the first?
Okay. Sir, I would like to keep rapidly progressive renal failure followed by acute onset.
Why not acute on chronic kidney disease?
Yes, sir, I would like to keep it also acute on chronic disease because
No,
she has
but
anemia,
then
hypertension.
tell me on clinically, can you, while you are giving you have given few positive finding in examination and many negative finding. But can you tell that what negative finding you should have told which can diagnose or exclude chronic kidney disease? Or in other words, what are the clinical finding on examination which can suggest chronic kidney disease?
Nails may show changes of chronic kidney disease like half nails, uh,
What else?
mimic fetor.
Like a half nail, then after that, can you speak little loudly, please?
There can be half nails, half and half nails. Then urinic fetor, uh, cachexia.
Anything else which are little more, probably more
Skin
specific for
changes,
saying
skin
chronic.
changes like
But nowadays, when she is already on dialysis, these changes are seen in very advanced, untreated chronic kidney disease. There, these things we hardly uremic fever and uremic frost. These are rarely seen. So there are some other thing which you should have told to suggest that okay, there is a unlikely to be chronic kidney disease or there is a possibility of chronic kidney disease. What about cardiac
contest.
examination to suggest chronicity?
Sorry, sir.
Cardiac finding which may suggest chronicity.
There can be changes of left ventricular hypertrophy.
So you should have told specifically negative finding to suggest your primary first possibility of a RPGN. So okay, now you have made after history and examination rapidly progressive glomerulonephritis and you are not sure whether lupus or ANCA or something else. Am I correct saying this?
Yes, sir.
Okay, so how you will investigate this patient?
Since she has anemia, we have to work up for anemia. We should
O-
see complete blood count. We should
Okay, just hold on. Now, these are blood counts. You can see, I think you haven't told me, if I correctly remember, she was admitted in Nagpur on 19th of March.
yes, sir.
Okay, so you have got these hematological parameter in front of you, and the arrow shows at the time of admission, and the last column investigation are 20th March. So,
Yes.
so interpret what you conclude after hematology.
So there is a severe anemia. It is less than 7 HB. MCV is low, 80, it is 78. MCH is also low, MCHC is low, MCHC is normal. And peripheral smear is showing microcytes, but it is normocytic, normochromic. So I would ask for iron studies, serum iron studies to rule out iron deficiency.
Okay, hold on. At the moment, there is a 2 month history approximately. Am I correct?
Yes, sir.
So, and if you see the 21st February values itself, she was already having 5.3 hemoglobin.
Yes.
So, why considering RPGN, how you interpret that she has low hemoglobin from the beginning? I mean, beginning or very early onset of disease.
If RPGN, in RPGN, usually anemia will occur. RPGN is anemia will occur. We have to rule out other cause of anemia like any SLE, any bleeding causing anemia.
But
As
that bleeding history you have already given. There is no history of the bleeding and there is no black color stool. There is no external bleeding.
yes, sir.
And she is reasonably economically okay. And so we can't, I mean, unlikely that nutritional anemia will be cause for this low hemoglobin.
Yes, sir. Uh, since it is showing microcytic and this region has high prevalence of sickle cell, I would like to rule out sickle cell also, sir. Hemoglobinopathy.
You want to exclude sickle cell also. And
Because
this reticulocyte count is 1.6%.
it is against hemolytic anemia.
Okay. So after doing hematology, because she was anemia, what next investigation you want to do?
I want to see the other cell lines, whether it is only single cell line affected or whether there is thrombocytopenia because I have kept TMA
No, but
also.
that you already seeing that the TLC is normal and platelet are also within normal limit, although little variable. So that
Yes,
is already you have seen in this slide.
yes, sir.
What
Now,
next?
I would like to see her RFT, LF, renal function test, liver function test.
So tell me why, what you want to see in in RFT with the background history you have already given.
It is only to confirm renal dysfunction, sir.
No, but his patient is already on dialysis. So suppose if the urea comes 80 and creatinine 2.3, what you will analyze once patient is already on dialysis? So after hematology, what else you will find if you do renal function test first?
No, sir, only to see whether, since she is on dialysis, it will not, only to see the adequacy of dialysis only we can see.
Do we really see adequacy of dialysis in a patient presenting acutely, whether RPGN or acute and chronic? Adequacy comes in a patient who is on maintenance dialysis.
Yes, sir.
So what next?
I would like to see the LFT, whether there is any hemolysis to see the
So
bilirubin.
you are going on renal function and LFT. Your differential diagnosis was what? RPGN versus acute and chronic.
Yes, sir.
So what
Yeah.
investigation will differentiate these two things? Will LFT differentiate these two things?
No,
Or
LFT will not differentiate, only to
then
rule out PMA, but it is platelet and all is normal. To differentiate between CKD and RPGN, we have to see for whether there is hypocalcemia, whether there is raised PTH in investigations.
now, will raised PTH or hypocalcemia, these two things really differentiate acute and chronic versus RPGN of 2 month history?
No, sir.
Then now you have to do investigation which confirm or out of your two differential diagnoses?
Yes, sir. I should go for serological investigations like
What serology?
ANA-IF, ANCA, C-ANCA, P-ANCA. If IF is negative, ELISA also both has to be done.
Hey,
Then
you should concentrate. Will these investigation, if any one of them is positive or negative, will it differentiate RPGN versus chronicity?
no, sir, it cannot differentiate
Tell me then
RPGN.
what is definition of RPGN?
RPGN is a clinical syndrome characterized by rapid loss of renal function over days to weeks. Uh, RPGN is also associated with oliguria, hematuria, or RBC, dysmorphic RBCs or erythrocyte syndrome.
So there is a two component, rapid progression and a glomerulonephritis. So what investigation you normally do to assess glomerulonephritis?
We will go for urine examination, sir.
Yes, so you have gone to calcium phosphate and LFT and serology without going for urine examination. That's what we normally do. We go for more sophisticated investigation first. So see, this is the urine examination. We have got 4 values of urine examination, starting from third week of February till end of March.
Okay, sir. Urine is showing proteinuria to albuminuria. Then it is also showing RBCs with RBC cast. So RBC cast is there. It is more likely to be glomerular hematuria. So RPGN is more likely.
And what about spot urine protein creatinine ratio and 24-hour urine? Does that differentiate anything out of RPGN, the two differential you were making of lupus versus ANCA?
Sir, proteinuria can be present in both lupus and ANCA.
If the degree matters,
Both can. No, so both can present with subnephrotic range protein.
okay. So by this urine examination, what is your out of those two diagnoses, which one you will favor?
RPGN, ANCA can present more as RPGN. In SLE can also present as RPGN, but it is only around less than 20%, 10 to 20%.
So by this, we still cannot say etiology of RPGN. We can just say that there is an active urine sediment and a significant proteinuria suggestive of glomerular disease. So we only can say glomerulonephritis. And what you were asking, renal function, this is renal function. So patient was already showing severe renal failure, and that we know because she required dialysis. So obviously she will be having severe renal failure. Now this is the hematological parameter which you wanted to assess for anemia. Now you interpret what is conclusion out of these investigation. You were saying that you want to assess iron deficiency.
Yes, sir. From this investigation, TSAT is more than 20%. There is no iron deficiency. B12 folic acid is normal. There is LDH is negative, which is against hemolysis. DCT is positive, but taking her history of blood transfusion, we cannot take it, we cannot interpret.
So can we say anything that why she has severe anemia from the middle of February?
From this, we have ruled out iron deficiency, hemolysis. So it could be renal origin also anyway.
Why the ferritin is 1320? Any interpretation?
Any inflammatory state can increase ferritin. It is an acute phase reactant.
So, but with your history and examination, what acute infective or inflammatory disease you want to explain high ferritin in this? Any other history which can explain high ferritin?
The blood transfusion.
Okay. So, what else you want to see? Other investigation?
Check X-ray to see whether there is any uh,
Okay, X-ray
system involved.
was not available. So these are other biochemical parameter which was done in this patient. If we need your interpretation, many of these things you were saying in which can favor out of these two diagnoses.
Calcium is normal. Phosphorus is high, but it will not help in differentiating acute between acute renal failure and CKD. LP is normal. PTH is slightly elevated. Vitamin D is low.
And what is on the right side?
HbA1c is 7.9. She
Okay.
says it is controlled, but target we keep around 7. She's an young patient, so it is higher. Albumin is 3.2. There is no significant hypoalbuminemia, and she's not having anasarc also, gross anasarc also. And urine is also not showing nephrotic range proteinuria.
Okay. So these are immunology, serology, which you were asking in between.
Yes, sir. ANA is negative, so it rules out about 97% of SLE will be usually ANA positive. Only 3% will be ANA negative. ANCA is positive, PNCA is positive. And C3, C4 is normal. So ANCA vasculitis is possibility.
You're saying ANCA is positive. Is the titer shown in the result really is definitely positive ANCA?
I think this is IF.
It was no, IF will not give titer. So this is borderline positive.
Yes, sir.
There's some more investigation, echo and ultrasound.
Echo is showing grade 2 diastolic dysfunction. And kidneys are almost 9.8 centimeters, a normal size kidneys.
So what next you want to do?
Since the kidneys are normal, I would go for renal biopsy.
There was HRCT was also done in this patient. Anything you want to comment on HRCT? Although I understand it may not be, you may not interpret HRCT, but anything gross you want to comment?
So there is some haziness in the lower lobes, ground glass opacities.
Ground glass opacity. Okay, I think we can escape CT scan, and there is MRI was also done. Although I don't know report and I will not be able to interpret also. We can escape with this. Then the renal biopsy was done. This is the light microscopy.
The renal biopsy is an adequate sample. There is 20 glomeruli, and all 20 are showing crescents, predominantly cellular. Cellular and 4 is fibrocellular. So it is crescentic glomerulonephritis. And crescents are of varying age. Some are cellular, some are fibrocellular, some are fibrous.
So
And
that suggests what?
Sir, it suggests that different glomeruli are in different stages of inflammation.
Hey, in terms of a etiology of crescentic glomerulonephritis,
ANCA vasculitis is more likely.
or you can say more of a systemic disease if there are crescent are of variable age, then it is more of a systemic disease suggestion. Anything else which suggests vasculitis?
There is fibrinoid necrosis in one of the capillary ducts, which again suggests vasculitis.
Okay. So this is light microscopy. What else you want to know in biopsy?
So I want to know about the immunofluorescence staining.
You want to know other detail because I have
Yes,
shown
sir.
you only glomerulus.
If it is 10 to 15%, which rules out underlying CKD, chronic disease. Tubules are showing cytoplasmic macular change, which is a feature of acute tubular necrosis. Then calcium oxalate.
So anything important?
Diabetic changes are not there, sir. Mesangial expansion or Kimmelston Wilson nodules are not there.
Yes,
Mm.
that is expected because of a just 5 year history of a diabetes, which you were saying the diabetes as a feature favoring chronic kidney disease.
Let's see.
So this is immunofluorescence which you were asking.
Yes, sir. Immunofluorescence, it is not showing any deposits. All IgA, IgM, C3, C1, kappa, and lambda is negative. So SLE is less likely. ANCA is more. It is post-immune present-ring glomerulonephritis.
Okay. So that was a summary of the histology given by the pathologist, and we can skip. I will not be able to interpret electron microscopy, and that is end of investigation. Which now tell me with this history examination investigation, ultimately diagnosis is what? Can you conclude the diagnosis?
Yes, sir. Diagnosis is rapidly progressive glomerulonephritis, present-ring glomerulonephritis, post-immune, small vessel associated, ANCA associated, small vessel vasculitis.
Why you are in RPGN, after saying RPGN, why you want to add crescentic glomerulonephritis also?
No, sir. RPGN is histological counterpart of present-ring glomerulonephritis only.
Is that correct? You means to say every RPGN will have crescent?
Yes, sir.
Mostly yes, but non-crescenting RPGN will also be there. And you have seen the histology. Suppose if I ask you now how you will treat this patient.
For treatment, considering ANCA vasculitis, we can go with pulse methylprednisolone, 500 to 1 gram for 3 days we can keep.
No, we are not going into detail of this. My only point was that the histology was showing 50% glomerular showing fibrocellular and fibrous crescent. And there is a 15% IFTA. And there are 50% glomerulus still showing cellular. So do you feel that how aggressive we should treat? I'm not going to what type of drugs and those things. Should we treat this patient aggressively or we should treat considering 50% glomerulus fibrocellular versus and cellular crescent? Should we be a little moderate and see the response initially and then go aggressive, or from the beginning we should go aggressive?
Sir, we should aggressively treat because majority are cellular crescents. But in guidelines,
No, it's all right. We are not going into theory of treatment. Dr. Vineet, from my side, I have done. Now, if we have got question answer in chat, maybe that can be.
Yes, sir. Dr. Jasmine, would you take the questions?
Yes, sir. Sir, someone has asked, like in anti-GBM disease, should we put it under the category of AKI or RPRF, like the broad clinical syndromic diagnosis of anti-GBM, which has a very acute presentation of like a week or so. So our clinical diagnosis will be AKI or RPRF in that case?
Dr. Jwala, will you like to answer?
Um, Sir, madam, I didn't hear the question. Can you repeat it?
Like anti-GBM disease, should we put it under the syndromic diagnosis of AKI or RPRF? And this is a very usual query which is seen in faced by students in exams, sir, that should we put the clinical syndromic diagnosis as AKI, AKD, or should we bring in RPRF in a case?
Syndromic diagnosis we make based on the presentation of the patient, how rapid the patient is presenting, the duration. So it will be based on how the patient is presenting. But anti-GBM usually presents abrupt presentation. It is more likely to present as RPGM. But when we put diagnosis, it should be always based on the clinical presentation and examination findings of the patient.
Hey, but Dr. Jwala, say somebody is presenting with moderate renal failure and a history is say 10 to 12 days duration, and there is a evidence of a glomerular disease in whatever, whether there is a clinical edema or microscopic hematuria and some hypertension, will that patient should be called RPGN or acute glomerulonephritis from that way or AKI?
Or AKD, like more than 7 days,
Or
10 days. Yeah.
Abrupt onset history of hypertension, oliguria, hematuria. It can be nephritic syndrome. If it
no,
is
that the question is that patient with this short history fits with acute glomerulonephritis. But by definition, the patient is also acute kidney injury.
Yes.
So out of this, which one should be more appropriate in terms of a discussion and approach of the patient also?
acute nephritic syndrome.
So that is actually problem is that acute kidney injury has been put taking only the deterioration in the renal function acutely. Now that can be because of the vascular thrombosis also, or that can be glomerular disease clear cut. So once there is a clear cut, in my understanding, acute kidney injury is primarily restricted to tubulointerstitial disease, whether ischemic or toxic, and the rest of the rest of the acute deterioration in renal function because of acute glomerulonephritis or RPGN or obstructive uropathy all becomes differential of acute kidney injury.
Okay. Sir, another query was the classical teaching was that hypertension is not seen in RPGN. So does that hold true? Like if a patient has hypertension, can we label him like RPGN and say that hypertension is probably because of fluid overload state or?
Dr. Jwala, answer.
Yes, sir. But it is told that hypertension is not seen in RPGN. But
Hey, sorry, is this statement is correct?
so I have read in books, but RPGN can present with hypertension. If you take lupus nephritis, it can present with hypertension.
I think if you read the books, then RPGN is not associated with severe hypertension.
Yeah,
Yes.
It's not
classical
hypertension.
teaching. Yeah.
And RPGN, which is caused by systemic disease like vasculitis and other, it may be associated with severe hypertension also. So it is initially we were differentiating RPGN in idiopathic RPGN and secondary and autoimmune. That was a strong point that if there is no systemic disease, then if there is a severe hypertension, is more likely to be chronic kidney disease rather than idiopathic RPGN. So we used to see fundus examination if there is a RPGN and fundus is showing grade 3 changes or papilledema, And if there is no systemic disease, then this patient is likely to be acute on chronic kidney disease rather than RPGN.
Yes, sir. Another interesting question is like now we all know that anti-complement inhibitors like avocapan have been used in ANCA vasculitis. So there is some involvement of alternate pathway of active complement. So why in the histopathology there is no complement deposition on IF? Even the alternate pathway is activated, still the histology is posse-immune in ANCA.
Dr. Jwala?
Sorry, sir.
I also do not know.
I also don't know.
Because this complement theory of pathogenesis of vasculitis has come in last decade or so.
Yes, sir.
These things are say like same. There is nothing all and none law. So some patient may have there will be at least no dominant complement deposition in histology in ANCA-associated vasculitis. Some complement may be deposited there.
Yes, sir.
So it's one part, I mean, it's only antibody against ANCA is not the only pathogenesis, even a complement also involved in pathogenesis. But how much component of these two favors in a particular patient may be difficult to extensively evaluate complement system.
Yes, sir. So another practical question was like, do we, in your practice, do you combine rituximab with cyclophosphamide in a case of severe dialysis-dependent ANCA vasculitis, or you just go with cyclophosphamide only? Or do you combine Ritux with cyclo in our Indian settings where we see a lot of infections?
I think if you ask my approach, ANCA vasculitis with requiring dialysis, I will go with steroid cyclophosphamide and plasmapheresis.
Another question was, is spot urine PCR reliable in dialysis-dependent renal failure patients?
Point is that in a patient who is dialysis dependent, probably the value of degree of proteinuria will be very little. In that case, 24-hour collection will be a little more reliable if we really want to assess degree of proteinuria rather than depending on a spot urine protein ratio.
I think, sir, we have covered almost all the questions that were asked in the chat box. Thank you, sir, for a very insightful discussion, and it was a very practical case-based approach. Another question was, sir, can we keep like two syndromic diagnoses in a patient, like as you said, AKD and another we can keep like RPRF also. Two syndromic diagnoses can we keep, or it will be
But
like
in this patient, AKD or AKI should not be differential diagnosis because here is a patient who has got clinical history of edema and there was some degree of some hypertension also, if I correctly remember. So once you have got evidence of any other differential of acute kidney injury, like glomerular disease or obstructive uropathy or thromboembolic, then we should put that as a differential rather than putting in a broad basket of AKI, because that is primarily misleading. I am in favor that if there is a clear-cut acute glomerulonephritis or RPGN suggestion, then syndromic diagnosis should be that rather than a big basket of AKI, which is really just saying that there is a renal failure, which is acutely developing clinically.
yes, sir. I don't know the answer to this, sir. Like, why hypertension is not seen in RPRF? Like the classical teaching textbooks teaching that hypertension is not seen in RPGN. So, what is the reason of that?
If you see renal disease degree or hypertension and its degree are probably twofold. One is that the deterioration in the renal function, and other is excess sodium absorption from the distal tubule. if you compare in a nephrotic syndrome, there are two group of diseases. One is non-proliferative and other is proliferative. Both has got nephrotic proteinuria, but one usually doesn't have hypertension, while other is having hypertension, while both may be having a normal renal function. So that is why the theory goes what is hypovolumic approach, explaining the hypovolumic approach in minimal change versus minimal change and membranous versus excess volume in membranoproliferative or IgA nephropathy or mesangial. So that may be explanation that RPGN may not have excess absorption of sodium from the distal tubule to put systemic hypertension. But again, I will say it's not statement given is that RPGN is not associated with severe hypertension. But many of RPGN will have mild hypertension, will not exclude RPGN.
Okay, sir. So another thing was in your clinical practice, when do you take the decision to just stop immunosuppression in a patient of ANCA vasculitis? Like the guidelines, we know they say like 4 years we can give immunosuppression, up till 4 years we have to give. Do you stop immunosuppression abruptly after 4 years, or do you do a biopsy after 4 years to see the disease activity, or like how do you stop? Taper and stop or abruptly stop?
If you ask my how I treat, it may be little different. I usually don't stop immunosuppression for 8 to 10 years unless patient is remain asymptomatic, no urinary activity, normal creatinine or stable creatinine. I usually continue a small dose of alternate day prednisolone, say 7.5 milligram alternate day for 8 to 10 years. And once there is no activity for 3 4 years, then I withdraw total immunosuppression. Otherwise, I don't withdraw total immunosuppression in systemic lupus or ANCA vasculitis. In both the disease, I don't withdraw immunosuppression. I've seen if you really follow theoretical, that patient has remained on remission for 2 years, then after that you can slowly withdraw the immunosuppression. And some people now theoretically are saying that histological activity cannot be assessed by clinical parameters, so they are going for biopsy before stopping or decreasing immunosuppression. But that is still has got many ifs and but, ethical clearance and whether in a stable patient, just to document whether there is a histological activity still going on. Maybe it is a debatable thing. Some people may follow, some people may not follow.
And so suppose if a patient is dialysis dependent for like 8 to 12 weeks, then do you continue immunosuppression even after 3 months in a patient of ANCA vasculitis to see for any late recovery, or do you stop immunosuppression if a
I,
patient is...
I think 3 month dialysis and still
Uh,
not recovering. The earliest recovering sign is increase in the urine output. Serum creatinine recover little later. But if somebody is requiring 3 months of a dialysis and 3 months of a regular similar degree frequency of dialysis, not that the initially patient was requiring thrice a week and then he started requiring twice a week and then once a week, then it means patient is still recovering. Then I will not withdraw. But if this is a stable thrice a week or twice a week and is still continuing with the same frequency, then probably time to decrease immunosuppression to the minimal degree. And again, do not stop completely because systemic flare may be still possible if you totally withdraw immunosuppression.
Sir, a question I wanted to ask, which is not related to the case, probably like in a case of crescentic IG or crescentic infection-related GN, when we decide to give a cyclophosphamide, so what protocol of cyclophosphamide do we give in a crescentic IgA? Do we use the UVAS regimen that we give in ANCA, or do we use the high-dose monthly cyclophosphamide regimen?
You are saying crescentic glomerulonephritis because of infection.
IgA nephropathy, say, sir.
because of IG nephropathy. You see, all glomerular diseases, if they are presenting clinically as a RPGN and histology shows crescent, then immunosuppression is advisable, even though if it is infection-related GN, because the course of disease is such that it needs to be immunosuppressed. I will not be able to answer that whether these patients, we were treating infective related glomerular disease only with steroid primarily. And in a short period of time, if patient doesn't respond, responding, then we used to add cyclophosphamide.
So,
Like this patient also. Now this patient is, although not, it looks more clear-cut acute, but it's still 50% glomulars are fibrocellular and those things, and the history is also at least 2 months is a history, then which means disease must be going on further 3-4 weeks before. I will probably have approached to give a pulse methylprednisolone and high dose of steroid for initial 3-4 weeks and see how she is recovering in terms of a urine output and in terms of a decrease in frequency of dialysis. And if she shows improvement in recovery, then after 2 weeks, I would like to add cyclophosphamide and give conventional treatment of vasculitis.
so in your practice, are you prescribing plasma exchange for every ANCA vasculitis patient who is having a creatinine of say more than 3 or 3.5, like the guidelines are recommending, or you are still giving Plex only to patients who are having DAH, or to every patient of severe renal failure you are giving Plex?
No, I am primarily giving Plex in patient who has got DH or dialysis dependent.
Okay, okay.
In absence of these two, primary treatment is steroid and cyclophosphamide.
Okay. Sir, we have covered almost all the questions. Thank you, sir. It was a very new sort of case discussion. Like we really liked the flow, how it went. It was a more of practical case-based discussion. Thank you all for joining us, and thank you, sir, for taking our bedsides. We thank you all, and we can now close this session. Thank you, Vineet, sir, and thank you, Dr. Jwala.
Thank you, sir. Have a good night, sir.
Good night.